Hi friends, welcome to classes by Lab Doctor. I am Dr. Divya, and in today's class, let us see what all we see in urine microscopy. We have dealt with many of the parameters in urine microscopy, but today let us see how the specimen is collected, how it is prepared for urine microscopy, what are the things we need to observe, what are the artifacts, what are the other things which we can see under the urine microscopy. All that we will study in today's class. So urine microscopy is a very important aspect of urine examination. It is called as the liquid biopsy of the urinary tract. That important is the urine examination under the microscope. So my urine जो है, it contains solid as well as insoluble elements in it which are suspended in a solution or a liquid. So these elements what are there in the urine, हम लोग उसको divide करते हैं as organized elements, unorganized substances etc. Like we have RBCs है, WBCs है, epithelial cells है, cast है, bacteria है, parasites है, ये सभी organized substances है. Crystalline substances, amorphous materials etc. We categorize it as unorganized substances. So main aim क्या है ये microscopic examination of urine करने का, टू आइडेंटिफाई ये सभी सेलुलर एलिमेंट्स को, कास्ट को, क्रिस्टल्स को आइडेंटिफाई करने के लिए वी नीड द यूरिन माइक्रोस्कोपी. सो जब आप एक यूरिन रिपोर्ट में देखोगे तो यू विल सी अ सेपरेट कैटेगरी दैट इज माइक्रोस्कोपिक एग्जामिनेशन. सो इट विल हैव पस सेल्स, इट विल हैव एपिथेलियल सेल्स, रेड ब्लड सेल्स, क्रिस्टल्स, कास, yeast cell, amorphous deposits, bacteria, protozoa. All these are the things which we are going to examine under the urine microscopy. We have dealt with each of these parameters in different videos. ये जो यूरिन रूटीन एंड माइक्रोस्कोपी में जो भी वीडियोस मैंने बनाया है, ये प्लेलिस्ट में there are videos on each of these. Like there are videos on WBCs, epithelial cell, RBCs in detail, so you can refer. This is in general what are we going to look in the urine microscopy. So I've told you the purpose of urine microscopy क्या है, हमको आइडेंटिफाई करने के लिए RBCs को आइडेंटिफाई करना, WBCs हो, कास हो, क्रिस्टल्स हो, बैक्टीरिया हो. सो ये एक वैल्यूएबल इंसाइट हमको प्रोवाइड करता है पेशेंट का किडनी एंड यूरिनरी ट्रैक्ट हेल्थ के बारे में. So now important thing is a specimen. So how do we collect the specimen? What type of specimen? So the cellular elements जो हम देखना चाहते हैं जो यूरिन में, that will be best preserved अगर हमने यूरिन का स्पेसिमन ठीक से कलेक्ट किया. अगर यूरिन एसिडिक है, हाइपरटोनिक है, देन दीज कास्ट हो या एलिमेंट्स हो, जो भी है सेलुलर एलिमेंट्स, वो प्रिजर्व होते हैं. यूजुअली फर्स्ट मॉर्निंग जो यूरिन रहता है, मिड स्ट्रीम यूरिन, फ्रेशली वॉइडेड यूरिन इज द बेस्ट वन. बट सपोज इफ यू कांट एग्जामिन द यूरिन, ऐसे आप बहुत ही लेबोरेटरी में बहुत ही पेशेंट्स है एंड you don't have the time to see the freshly void urine, at least you should make it a point कि आप within 2 hours of collection उसको examination कर दे. अगर वो भी नहीं हो पाएगा then you should at least put some preservative, or you might even you have to refrigerate. So it is always better to examine within 1 to 2 hours of voiding, because the cells है या जो कास है वो they will start degenerating. So if you are suspecting delay, you can either refrigerate, which many of us do, at 2 to 8 degree. It is not frozen, it is refrigerated at 2 to 8 degree, or sometimes you might even add a preservative like formalin or thymol can be used. And there are different ways of examining the urinary sediment. There are bright field microscopy, there are phase contrast microscopy, polarizing microscopy, etc. This becomes important because what you see under the Hyalin cast here, you can see under a bright field, but what you see under phase contrast, it becomes easy. So if there are facilities, and sometimes we do need this to identify certain casts or crystals, so all this would be correlated better, which will will be identified better if we use the different kind of microscopy along with a light microscopy. But light microscopy is the crux for urine examination. So how do we prepare a sediment? So हमको क्या करना होता है, 5 to 10 ml of urine लेना है, उसको centrifuge करना है. At about 5 minutes तक हमको centrifuge करना है, around 3000 rotations per minute. So then we discard the supernatant and जो भी वो sediment जो रहेगा उसको हम थोड़े से वो either normal saline या supernatant के साथ मिला के we will take it on a glass slide and then examine it under the microscope by putting a cover slip. So this is how the deposit is made and examined under the microscope. So first you should always scan it under the low power and then you should go to the high power. Suppose sometimes if there are too much of amorphous deposits etc है, आपको कुछ ठीक से नहीं दिख रहा है, then you can add a small drop of 10% acetic acid to dissolve all the amorphous deposit, but you should not excessively use it because it will also this acetic acid will prevent the cast dissolution also. So this is how we collect the urine, we centrifuge it, we discard the supernatant and we make the slides and examine it under the microscope. Sometimes it is stained also in certain cases. So now the urine sediment, I've told you, it should be examined under both low power for RBCs, WBC, crystals, etc. and for high power for dysmorphic RBCs, other crystals, bacteria, yeast, etc. to identify the exact morphology. So elements of urinary sediment contains cells, those are the RBCs, WBCs, epithelial cells, oval fat bodies. All of this we have discussed in detail. There are casts which we have classified as cellular and non-cellular. So cellular are RBC cast, WBC cast, epithelial cell cast. The non-cellular cast are your hyaline cast, granular cast, waxy cast, fatty cast, broad cast. Then you have crystals. There are certain normal crystals and abnormal crystals. Which are the normal crystals? Uric acid, calcium oxalate, amorphous urate, calcium carbonate, phosphates. All these are the normal crystals. Cysteine, cholesterol, bilirubin, leucine, tyrosine, sulfonamide. These are the abnormal crystals. Sometimes we even see certain bacteria, yeast, Trichomonas vaginalis, microfilaria, Schistosomia hematobium. All these are certain organisms which can be seen in the urine, and sometimes we see artifacts as well as sperms in the urine. So RBCs in the urine we have dealt it in detail, but remember these RBCs, they are yellowish structure, biconcave structure. They can vary in shapes and sizes also sometimes, and whenever you keep this urine, when it becomes hypertonic urine, sometimes it becomes crenated. So why it becomes important? Usually up to 3 RBCs per high power field we take it as normal, but suppose if you are getting more RBCs, then you should suspect whether there could be a glomerular disease, especially glomerulonephritis, lupus nephritis. Sometimes in case of non-glomerular diseases also, like in case of a stone or a pyelonephritis or a polycystic kidney, a trauma, an infection, that time also you can see the RBCs in the urine. So these are the RBCs. Some of them have become crenated, so you can see the clear morphology of the RBCs. Then comes the WBCs. So WBCs are, they are around round, they are granular, they are around 12 to 15 microns in diameter, and WBCs sometimes you get confused with the RBCs. So sometimes to differentiate WBCs from the RBC, we add and dilute acetic acid. RBCs will be lysed, whereas the WBCs, the nuclear characteristic of WBCs will be much more clearer. So the significance of WBC is that usually up to 5 WBCs per high power field might be present, but suppose if the WBC is more than 5, more than 10 WBC per high power field, usually it suspects we suspect a urinary tract infection. We need to clinically correlate it with the other findings also, and suppose in the urine you will see there are white cells, white cell casts, that all indicates that there could be a infection. For example, pyelonephritis, lower urinary tract infection, tubulointerstitial nephritis, renal transplant rejection, etc. So these are the WBCs. You can see the granular nucleus of the WBCs. Epithelial cells, these are the round or polygonal cells. Usually it is mostly the contaminant which is present in the urine, but there can be squamous epithelial cells, tubular epithelial cells, and transitional cells. So I have told you the significance. Very few squamous epithelial cells are present in normal urine, much more common in female because of the sloughing of these areas. And if there are renal tubular epithelial cells, usually it suggests that there is a tubular damage. So this is a squamous epithelial cells, this is a transitional epithelial cells, and this is the renal tubular epithelial cell. So these are the normal ranges of the epithelial cells in the urine, and if you find it beyond that, so usually there could be a renal tubular necrosis, or there could be renal tubular damage which is causing the shedding of the epithelial cells. So these are the various conditions where you can see the epithelial cells in the urine. Most commonly contamination, urinary tract infection, glomerulonephritis, kidney stones, certain kinds of cancer, in benign prostatic hyperplasia, diabetes mellitus, menopausal women, etc. Then coming to the casts. So casts are nothing but these are the substances which are formed by the molding in the renal tubules, that is in the distal connecting tubules or the loop of Henle. So these are basically TAM phosphol protein which is secreted by the tubular cells, which forms the matrix. So there are mainly two types of casts. One is non-cellular and cellular. So you will see that this is a hyaline cast, this is a cellular cast, this is a granular cast, and this is a waxy cast, which we have discussed in detail about each cast in our previous video. So you can have a look at all those videos to get a clearer and much better understanding. So the hyaline cast is nothing but it is made up of only the TAM phosphol protein. So these are cylindrical, colorless, homogeneous, transparent, and sometimes you can even see them in healthy persons, like in case of severe dehydration, certain diuretic medicines, etc. The granular casts are nothing but they have a coarse granules on a matrix. So after certain strenuous exercises, or in case of pyelonephritis, acute tubular necrosis, we see it as granular casts. Waxy casts represent the final stages of a degeneration of a cellular cast. Same thing with the fatty cast. They are formed by the breakdown of the lipid-rich epithelial cells. So usually in cases of nephrotic syndrome, etc., there you can see this fatty cast. RBC cast, they have RBCs in them and they lie on the protein matrix. You can see them most commonly whenever there is a glomerular damage, glomerulonephritis, etc., nephritic syndromes. WBC casts contain the WBC. Mostly they are neutrophils, and you can see them in cases of pyelonephritis, interstitial nephritis, etc. We also see crystals in the urine. Crystals are nothing but refractile structure with a definitive geometrical shape. But there are certain crystals which do not have any shapes, etc. What we call them as amorphous crystals. So there are certain crystals which we see normally in acidic urine, like the calcium oxalate crystals or the uric acid crystals. And there are certain crystals which we see in alkaline urine which are quite normal, like triple phosphate crystal, calcium carbonate crystal, ammonium biurate crystals. We have made previous videos wherein we have discussed about each of these crystals also in detail. You can have a look at that. So there are certain abnormal crystal like tyrosine crystal, cysteine crystal, cholesterol crystal, sulfonamide crystals when the patient is on sulfonamides, etc., bilirubin crystals, leucine crystals when there are inborn errors of metabolism, etc. We can get these crystals. So these are the various crystals. You can see a uric acid crystal which is elongated, and you can see a calcium oxalate crystal which is having this envelope shaped. You can see a calcium phosphate crystals. We're seeing such broadened ends, and you can see arranged in a fan shaped structure. These are the triple phosphate crystals which we usually see the coffin lid appearance of them, the calcium carbonate crystals, the ammonium biurate, the apple thorn appearance of these crystals, bilirubin crystals which are abnormal, they have this yellowish tinge, cholesterol crystal, these are flattened crystals you can see, and the broken edges here. You can see the cysteine crystals, and you can see the leucine crystal. Leucine and tyrosine inosine usually exist together. These are needle-shaped crystals. Sulfa crystals, which look like a haystack. Acyclovir crystals when a patient is on acyclovir, and indinavir in cases of HIV, antiretroviral medicines, etc. When the patients are on these medications, patients might pass few of these crystals. Sometimes we also see sperms in the urine. So this spermatozoa may be present in the urine whenever the patient is having retrograde ejaculation, or after a sexual intercourse, or whenever there is nocturnal emissions, patient is having convulsions, etc. The time the sphincter can sometimes get relaxed, and then you can throw out these sperms in the urine also. So this is a case of retrograde ejaculation. So you can see the testis, the epididymis, and the vas difference which has come here, the seminal vesicle which join to form the ejaculatory duct, and they ejaculate it here. But sometimes what happens, because of this there is a retrograde ejaculation because of the internal urethral sphincter getting lax, etc. This semen, what is there, it can go backwards into the urinary bladder and then get excreted into the urine also. There are certain bacteria also which we see in the urine, and in wet preparation the bacteria should be reported. Sometimes when you keep the urine for a long duration without examination, you will get bacterial contamination. So gram staining of the sediment of the smear also can be helpful to identify the bacteria. Whenever there are bacilli, if there are associated pus cells, etc., that indicates UTI. Suppose if there are only bacteria, there is a very clear background, there are no neutrophils or there are no pus cells, then the indication that it could be just a contamination. So if you are seeing without pus the bacteria only, then it could be contamination with the vaginal or skin flora. So sometimes what happens is, this bacteria you can see rod shaped, you can see chain, or in the form of cocci. So acid fast bacilli can also be seen in the urine sediment, but because of the urethral flora may contain non-pathogenic acid fast organism, whenever you want to identify the AFB for TB, the urine must be cultured or substantiated by other methods, like either AFB culture or by PCR methodology. These are the yeast cells which are seen in the urine. They are round, they are oval, they are refractile structures. Sometimes you might mistaken them for the RBCs, but you will see this kind of a budding which you see in the yeast but not in the RBCs. So when you see such yeasts in the urine, it could be just a contaminations also sometimes. Sometimes it is the immunocompromised state of the patient. Patient is diabetic, patient is an HIV patient, patient is on immunosuppressant drugs, on steroids, etc. Then there are chances that you might get these yeasts in the urine. Sometimes we get few parasites in the urine, and they happen mostly because of vaginal contaminations. So whenever you see such parasites, like it could be Trichomonas vaginalis, or you can see Cystosoma hematobium, etc., you should perform this examination on a fresh and cleanly void urine sample. So whenever you see Trichomonas vaginalis, the protozoa should be searched for immediately in a wet preparation of the sediment, and because it is moving, it helps us to identify this parasite. And schistosomiasis, which happens because of the Cystosoma hematobium, you can see the typical ova which is directly shed into the urine, and it is there will be bleeding. So you can see the RBCs in the urinary bladder, or the urine sample will have the RBCs. We also see the urine for the tumor cells, malignant cells which are exfoliated. It could be from the renal pelvis, or from the ureter, or from the bladder wall and the urethra. So they are usually best identified when we used the cytologic techniques. Sometimes you even see the myeloma cells also in the urine, both with or without the renal involvement. So then there are artifacts which we can see in the urine, which can be mistaken for RBCs, for casts, for crystals, etc. Like you have the starch granules, you have the fibers here, you can see an air bubble here. You can see here also there are air bubbles. So these are again the different types of artifacts. Here you can see a hair. So here you can see a pollen grain, which you can mistaken it for a crystal. Here you can see a talcum powder, or you can see sometimes glove powder. Here you can see the air bubble, which sometimes we mistake it for RBCs. Here you can see fat droplets. Here you can see the cloth fiber. So these are the various artifacts, and we need to differentiate it from the actual cast, crystals, cells, etc. So that is all about urine sediment examination under the microscope. Thank you so much for watching the video. Please like, share and subscribe the channel. Thank you.